Our next speaker will be Dr. James Schuster. Dr. Schuster is the Chief Medical Officer of Community Care Behavioral Health, which is based in Pittsburgh and is connected with the University of Pittsburgh Medical Center. Dr. Schuster will speak on the rates of benzodiazepine use and medication-assisted treatment from CCBH counties. Dr. Schuster.
Thanks very much. I'm also pleased to see everybody here. And I want to thank Roland Lamb from CBH and Peter Longo from IRETA for allowing us to join them this morning in this effort to really develop some guidelines and ideas around, the theme is really benzodiazepine use in methadone treatment, but I think the challenge we all work with is really concurrent addictions for folks in methadone treatment and management of concurrent anxiety. I have a few slides that I'll walk through. I was at a meeting yesterday where people talked about death by PowerPoint, and I think the people I work with would be happy if I stopped at that time, but I'll try to limit it. This is a theme that we've been working on at Community Care for now the past couple of years, and it was really stimulated by a call from a provider who contacted us and said, this is really a very challenging issue for us to work on, and we know that there are groups of people in Philadelphia who are working on it, and CBH is helping them, so can you help us in this part of the state? And we said we'd be happy to do that. But that was really the origin of our interest. I know there are a lot of people here from Philadelphia, so I wanted to just say a word about who Community Care is. We're a behavioral health managed care company. The company was founded back in 1996, and Mike Flaherty, whom many of you all know from his work as the founder of IRETA, was also a co-founder of Community Care back in that time. We're a tax-exempt organization, and we're a part of UPMC. And the focus of the company really is on publicly funded behavioral health services. We work with about 680,000 Health Choices members across the state. And unlike Philadelphia, where CBH is really part of the county system, the other counties in the state managed care companies work in partnership with the counties. So we really work for the other counties where we work. So these are the counties that we work in across the state in the different regions. And then in addition, we're doing some work in New York in what they call the Hudson River region, some managed care behavioral health work, which goes from Westchester up to north of Albany. So what I wanted to do this morning was really to provide some Pennsylvania-specific data to really complement the national numbers that we just saw. We actually started out by looking at the use of benzodiazepines generally in the population, not just for folks in methadone, but generally in the population. And what we found was that fortunately, the utilization is really very low among children and adolescents, but the use among adults is really non-trivial. This is not, again, adults in methadone programs. This is just the general adult Medicaid population. And the way that we do the analyses is look at how many adults in any one quarter have received a particular class of drug. And so in any one quarter, and it ranges, again, from one part of the state to another, but between roughly 10 and 15% of adults will get a benzodiazepine prescription in a particular quarter. So it's really a non-trivial number. We did go and, around the time we've been doing this work, we saw there was a study published from Baltimore, actually, in the British Medical Journal. And, it was congruent, I think, with all of our experiences, but showed that there was a lot of methadone use and abuse, and that individuals who abuse benzodiazepines are at increased risk of continuing abuse and really not engaging in treatment. They did a survey of folks in the program, and they found that 47% of the folks reported using benzodiazepines. 25% said their use began with a prescription. And then I thought the last point was interesting, which is half of the folks using benzodiazepines in methadone treatment actually didn't start using the benzodiazepine until after they were in methadone treatment. So it was really, another juncture in their addiction, it really looked like for many people. people use benzodiazepines and for reasons that that we've all heard. But I thought one of the other points that was interesting was, when the patients were asked if they would consider reducing or stopping the use of the benzodiazepine, roughly half said that they would, and of the half who said they wouldn't, most of those had actually already stopped using the benzodiazepine. So, it's clear that if it's presented as an issue to patients in treatment, that many people are interested in really trying to get support to reduce their use. I mean, they realize that there's an addiction and an issue that they need to address. So I wanted then just to present a brief summary of some work that we've done over the last couple years with methadone providers in several of the regions that we work in. The data that I'm going to show you is from Allegheny County, just because the program's been underway there the longest, so we have the most extensive kind of time period of data to share. But the themes are really similar in all the different regions that we work in. So what we started off was really trying to identify members who were enrolled in methadone treatment programs who were concurrently filling either benzodiazepines or opiate prescriptions. And what you found, this really looked at the frequency of benzodiazepine use. Again, this is in Allegheny County. And you can see starting from the third quarter of 2009 and then going to the third quarter of 2011, in the 30% of folks get a prescription in any particular quarter. So this, obviously, we're working off pharmacy claims data. We don't know how many additional people might have gotten meds illicitly from the data that we have. But this is just people who had prescriptions filled. And, clearly people might get a prescription filled and then not take it or, sell it. But our assumption is most of the people are getting them filled or probably using them. So we met with the providers and talked about what might be helpful to them. And I think this was an activity that actually started in the Philadelphia area, where some of the providers would actually get a monthly report of prescriptions that the members had filled. So they would know if the person was getting benzodiazepines filled. Obviously, people also do drug screens. But this was, we thought, something that might complement the drug screen, providing an additional source of information. So we've been doing this now over the couple years. And we did, so we were wanting to address really benzodiazepines and opiates. And so you can see in 2009, we identified about 550 folks in methadone treatment in Allegheny County who were, had at least a couple weeks of methadone claims and had a benzodiazepine filled in the same quarter. And you can see 43% of those folks had benzodiazepines filled and 31% had opiates filled. Some were on both. So then if you go out almost 2 years, of those 556 people who started out in treatment, about 400 were still in methadone treatment. And of the people still in methadone treatment, the rate of benzodiazepine use really was not changed. The rate of opiate use actually went down quite a bit, of concurrent opiate prescription use. And many of the people, a significant number of people were on no medications, but the rate of benzodiazepine use really hadn't changed all that much. I have to say there's several providers in Allegheny County, two of the providers who I'm sure not coincidentally are here today really have made significant progress. I wanted to recognize them. One was Dr. Dewey, who's here from Western Psychiatric, and Dr. Reese, who's here from Tediso. So it's clearly an issue that can be addressed, I think, at the individual patient-client level, but it clearly requires pretty intensive efforts on the provider. It's certainly not an easy issue to address. So this is really just another format of the numbers we were looking at before. And we are doing this, we have started this project in some other counties that we work in, and now the other counties we work with have all expressed a desire to start the same project, and it'll be starting soon. We've talked with the providers about some additional interventions that might support their work. One of the things we talked about is sometimes members will patients will leave one provider if they're confronted with a concurrent benzodiazepine use issue and then show up at another provider. And so I know there's information shared between providers, but we talked about potentially some interventions that might help support that. We also talked about trying to reach out and engage members who might have left a program because they were having trouble with the treatment plan outlined with the provider, and see if some additional interventions, either treatment or recovery specialist or other initiatives, might be helpful to them. And then we're also working on some material to send out to prescribers. Clearly, we can't tell the individual prescriber somebody's in methadone treatment because of confidentiality rules, but we can certainly tell them, you know, this is kind of an aggregate what we found around folks in methadone treatment. We've done similar analyses around buprenorphine, which the rate of use among folks on buprenorphine is lower, but still significant. But to send information out to prescribers to let them know that these issues exist and encourage them to consider really careful evaluations around addiction before they're prescribing benzodiazepines. And there clearly, as you might suspect, there's variation among prescribers in terms of how many prescribe benzodiazepines for different members of the population. And so for the folks who prescribe a lot, we might do some especially intensive education or support. We're also working to really try to talk with the physical health plans who pay for the medications. And many of the prescriptions are from psychiatrists, but many are also from primary care practitioners. And so we really want to try to approach the primary care docs in partnership with them. So that's a brief summary of kind of both the data and some steps taken. And we're looking forward to the discussion today and some ideas about additional steps to take, because it clearly is a really challenging issue. There's clearly not a solution, but it's clearly, like most things in life, going to require multifaceted intervention. So we're looking forward to the discussion and ideas. Thanks.
Thank you, Dr. Schuster.